Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host Adam Khan, and joining me today is Ahmed Altayeb, who's going to take us through the amazing world of the ear, its anatomy, hearing, balance, and even a clinical case at the end.
Hey Adam, thank you for having me. I'm really excited to be here. Today, we're covering one of the coolest sensory organs we've got that we take for granted most of the time. The ear is a small and compact structure, but is packed with an intricate design and very cool functions. There's a lot more going on here than just listening to your favorite playlist.
Yep, so here's our roadmap for today. We'll start with the anatomy of the external, middle, and inner ear. Then, we'll cover the physiology of hearing, the systems behind balance, and wrap it up with a real-life clinical case that ties it all together.
Perfect. It's going to be a packed episode, but don't worry, we'll take it step by step. Now, let's get started.
Alright, let's begin with the external ear. Ahmed, please walk us through this.
Sure. So, the external ear consists of two main structures, the auricle and the external auditory canal. The auricle, made of fibrocartilage, plays the key role of collecting sound waves and directing them into the canal. It might seem simple, but even the folds help filter and amplify sounds. Now, we have the external auditory canal, which is split into two parts. The outer third is cartilaginous and lined with thick skin containing hair follicles, sebaceous glands, and ceruminous glands. The inner two-thirds is bony, formed by the tympanic part of the temporal bone. It's lined with much thinner, more delicate skin, with no glands or hair, making it more sensitive. The ceruminous glands are responsible for producing cerumen, or earwax. And although cerumen has a bad reputation, it's actually incredibly useful. It traps debris, repels insects, and prevents water from reaching the delicate structures deeper inside the ear.
So it's not just about hearing. The ear is already in defense mode right from the start and has a built-in system to protect itself. The way the canal changes from soft cartilage to solid bone deeper in is actually pretty brilliant when you think about it.
Agreed. It's honestly crazy how well thought out everything is. Now, if we talk about nerve supply, things get surprisingly complex. The auriculotemporal nerve, a branch of V3, which is the mandibular division of the trigeminal nerve, innervates the anterior and superior auricle. The greater auricular nerve, from the cervical plexus C2, C3, handles the lower parts of the auricle, like the lobule. Now finally, we have the lesser occipital nerve, also from C2, C3, which supplies the upper cranial surface behind the auricle.
Wait, doesn't the external auditory canal also receive fibers from the auriculotemporal nerve?
Yes, you're right. However, this time, it's not just supplied by the auriculotemporal nerve, but it's also innervated by the auricular branch of the vagus nerve, also known as Arnold's nerve, as well as minor contributions from the facial nerve.
Right, and that complex innervation really explains why sometimes patients might cough or even feel nauseous during an ear exam, doesn't it?
Yep, so stimulation of the vagus nerve branch can trigger reflexes like coughing, nausea, vomiting, or even bradycardia and fainting, especially in children and the elderly. That's why being gentle during otoscopic exams is very important.
Noted. Moving onwards, why don't you tell us more about the tympanic membrane?
Well, the tympanic membrane, or the eardrum, is a thin, semi-transparent oval membrane that separates the external ear from the middle ear. On otoscopic examination, it usually appears pearly grey and slightly concave. It's anchored around its edge by the tympanic annulus, which is a fibrocartilaginous ring that fixes it to the temporal bone. Now, when the tympanic membrane is viewed through an otoscope, you'll notice the umbo, where the tip of the malleus handle connects, the handle of the malleus itself running upward and anteriorly. You have the pars tensa, the tightly stretched out and functional portion of the membrane. And finally, we have the pars flaccida, which is more lax and sits above the malleolar folds. If everything is healthy, you'll also catch the cone of light, which is a bright triangular reflection located antero-inferiorly on the membrane.
So when we look in with the otoscope, a nice pearly grey membrane, a visible malleus handle, and a clean cone of light tell us that everything's looking good. It's pretty cool how the otoscope tells you a story if you know what you're looking for.
Bingo! And as for nerve supply, the tympanic membrane receives its primary innervation from the auriculotemporal nerve of V3, again, but also from the tympanic branch of the glossopharyngeal nerve and the auricular branch of the vagus nerve.
Oh, didn't we mention earlier with the canal that stimulating structures innervated by the vagal nerve can provoke coughing, bradycardia, and all those other symptoms? It's honestly really amazing how the ear isn't just a passive structure. It's so sensitive and wired into major reflex pathways.
You're absolutely right, Adam. Every tiny part has a huge job to do.
Alright, Ahmed, now that we've passed the eardrum, what's next? What's the middle ear all about?
So now we're inside the middle ear, or what's called the tympanic cavity. It's basically a small air-filled chamber carved into the temporal bone. On one end, it connects laterally to the external ear via the tympanic membrane, and on the other, it communicates medially with the inner ear through two key openings, the oval window and the round window.
So it's like a hidden chamber sitting between the outer world and the inner ear.
Exactly. And just like any room, the middle ear has walls. 6 walls, actually, and each one neighbors major structures.
Right, wait. 6 walls? Walk us around this tiny room.
All right, let's take a quick tour. Starting with the lateral wall, that's the tympanic membrane, the eardrum you just passed through. Above you is the roof, called the tegmen tympani. It's a thin plate of bone that separates the middle ear from the middle cranial fossa, also known as the brain. So, if there's an ear infection, it can sometimes sneak its way into the cranial cavity.
Oh, okay. So the roof isn't very protective. Thin roof means easy brain access.
Yep, exactly. Next, we have the floor, or jugular wall, which sits just above the internal jugular vein. Now, the medial wall, also called the labyrinthine wall, faces the inner ear. This is where we find the oval window, round window, and a bump called the promontory, created by the basal turn of the cochlea.
Okay, so oval window, round window, promontory, all on the inner side.
Yep, exactly. And covering the promontory is the tympanic plexus, which is a nerve network mainly coming from the glossopharyngeal nerve. Now, moving to the front, the anterior wall, you're right next to the internal carotid artery. This wall also has openings for the auditory tube and the canal for the tensor tympani muscle.
So front wall equals carotid artery and auditory tube. Got it.
Perfect. Finally, the posterior wall opens up into the mastoid air cells through the additus to the mastoid antrum. Now, this is very important clinically. Remember that this posterior wall is close to the facial nerve, running inside its own canal.
So the posterior wall leads into the mastoid air cells and it's also dangerously close to the facial nerve, right? That explains why serious middle ear infections can sometimes lead to facial paralysis. Just imagine an ear infection causing a droopy face. Anatomy really doesn't matter.
It really does.
Okay, so every one of these walls is basically high stakes real estate: brain, carotid artery, jugular vein, cochlea, facial nerve.
Exactly. It's small, but absolutely packed with very important neighbors. Now, sitting inside this cavity are the ossicles, the malleus, incus, and stapes.
Oh, wait, I remember hearing about this online. Aren't those the smallest bones in the whole body?
Yes, they are. The malleus connects to the tympanic membrane. The incus links the malleus to the stapes. And finally, the stapes sits on the oval window. Altogether, they act as a mechanical amplifier, transmitting and boosting sound vibrations from air into the fluid-filled inner ear.
So without them, we'd basically lose sound energy, no?
Absolutely. The ossicles amplify sound pressure by about 22 times, thanks to 2 tricks: lever mechanics between the bones and a huge surface area difference. The tympanic membrane is much larger than the stapes footplate, which concentrates the force.
Got it. Small bones, huge impact.
Could not have said it any better. Now, to prevent damage to the ear from very loud sounds, we have 2 protective ear muscles, the tensor tympani and the stapedius.
Ah, there is built-in volume control?
Yes, the tensor tympani, innervated by V3, mandibular branch of trigeminal, attaches to the malleus and tenses the tympanic membrane to reduce vibrations and dampen sounds. The stapedius, which is the smallest skeletal muscle in the human body, is innervated by a branch of the facial nerve, cranial nerve 7, and pulls the stapes away from the oval window to reduce its movement.
So when there's sudden loud sounds, these muscles reflexively pull tight to protect the inner ear. I'm pretty sure this is called the attenuation reflex. It kicks in about 40 to 80 milliseconds after loud sound exposure, and it can reduce the intensity by about 30 to 40 decibels, which is honestly amazing. It's practically built-in soundproofing.
Yes, exactly. And if the facial nerve is paralyzed, for example, in Bell's palsy, the stapedius can't work properly, and you get hyperacusis, which is when sounds seem abnormally loud and painful.
Alright, Ahmed, before we leave the middle ear behind, I'm seeing a lot of scary stuff on this diagram. Brain abscesses, meningitis, facial nerve palsy. Can infections from the ear really get that serious?
Unfortunately, yes. Infections like otitis media can start in the middle ear, but if left untreated, they can spread through different pathways and cause some pretty dangerous complications. Let's walk you guys through this step by step.
Alright, I'm all ears. You see what I did there?
Yeah, hilarious. So, it usually starts with a simple pharyngitis, an upper respiratory infection. Because the auditory tube connects the pharynx to the middle ear, the infection can travel upward into the tympanic cavity. Once it reaches the middle ear, it causes otitis media, the buildup of pus and pressure inside the tympanic cavity. That's when you start seeing the tympanic membrane bulging outward on an otoscopic exam.
That's the classic red, bulging eardrum we always hear about in otitis media.
Yep, exactly. Now, if the infection isn't controlled at this stage, it can break through the thin roof of the middle ear, the tegmen tympani, and spread into the cranial cavity. When it does that, it first forms an epidural abscess.
Epidural abscess, so a pocket of pus sitting just above the dura.
Exactly. And from there, it can progress further inwards, infecting the meninges and leading to meningitis.
Meningitis is definitely not something you want to mess with.
Not at all. And if the infection digs even deeper into the brain tissue itself, it can cause a brain abscess. It's crazy how one simple ear infection can, if left untreated, spiral into life-threatening intracranial problems.
That's honestly terrifying. And I see on the diagram something about sinus thrombosis too.
Good catch. If the infection spreads via venous channels, it can lead to lateral or sigmoid sinus thrombosis. Basically, clot formation in the major dural venous sinuses. That can cause serious drainage problems from the brain and lead to increased intracranial pressure.
Wow, and that's still not all. I also noticed something about facial nerve palsy.
Yeah. Remember how close the facial nerve runs to the middle ear? If the infection spreads towards the facial canal, it can inflame or compress the facial nerve, leading to weakness or complete paralysis of facial muscles on that side.
That would show up as things like droopy face or trouble closing the eye.
Exactly. And lastly, if the infection spreads posteriorly through the mastoid antrum, it can reach the mastoid air cells and cause mastoiditis. That presents with pain, swelling, and redness behind the ear.
So one simple ear infection can potentially become brain infections, nerve paralysis, blood clots, or mastoid infections. That escalated fast.
Very fast. That's why recognizing and treating otitis media early is so important, not just to save hearing, but literally to save lives.
All right, Ahmed. So far, we've covered the external ear and the middle ear. Now, onto the part that feels like a total black box, the inner ear.
Right. So the inner ear is where the real magic happens. It's a tightly packed, very sophisticated system responsible for both hearing and balance. Structurally, it's divided into two main parts, the cochlea and the vestibular apparatus.
So it's like two departments sharing the same building, one for hearing and one for balance?
Yep, exactly. So the cochlea handles hearing, while the vestibular apparatus, which includes the utricle, saccule, and semicircular canals, takes care of balance and spatial orientation.
All right, let's start with the cochlea. What's it like inside?
The cochlea is a spiral-shaped snail-like structure. Imagine a tiny spiral staircase curled inside your ear. Inside the cochlea, there are three main fluid-filled chambers: the scala vestibuli, the scala media, and the scala tympani.
What's inside each one?
So the scala vestibuli and scala tympani are filled with perilymph, which is very similar to extracellular fluid, high in sodium and low in potassium. The scala media, or cochlear duct, is filled with endolymph, which flips that balance: high potassium, low sodium.
Okay, wait. So perilymph is like the body's regular default fluid, but endolymph is the special potassium-rich fluid just for the cochlear duct.
And that special endolymph is critical because it allows the hair cells to function.
Speaking of hair cells, this is where the organ of Corti comes in, right?
Yeah, exactly. Sitting inside the scala media, on top of the basilar membrane, is the organ of Corti. It's the true sensory organ for hearing.
And what's in it?
So it's packed with rows of inner and outer hair cells. The inner hair cells are the ones that do most of the actual work. They turn mechanical sound waves into electrical signals that the brain can understand. The outer hair cells are more like the cochlea's sound engineers. They fine-tune and amplify specific sounds.
So inner hair cells equals signal makers, and outer hair cells equals sound tuners.
Yeah, you're on the right track, Adam.
Okay, mini recap. 3 chambers: scala vestibuli, scala media, and scala tympani. Perilymph in the vestibuli and tympani. Endolymph in the media. Organ of Corti sits in the media and converts sound. Got it so far?
Perfect. Now, one last thing to mention. The endolymph's high potassium content is essential because when sound waves hit, they cause the hair cells' stereocilia to bend, and potassium flows into the cells, triggering depolarization.
So potassium is like the battery that fires off the hearing signal.
Precisely.
Now, let's put it all together. How does a sound wave turn into something our brain can understand?
Let's start at the beginning. So sound waves first enter the external auditory canal and hit the tympanic membrane, making it vibrate.
These vibrations are passed onto the ossicles, right? The malleus, incus, and stapes, which act like a lever system to amplify the sound like you mentioned earlier.
Exactly like a lever system. And because the tympanic membrane is about 17 times larger than the oval window, that surface area difference also boosts the pressure. increasing the sound energy by roughly 22 times.
22 is a huge number. That's a lot of amplification. And to protect the ear from overly loud sounds, we've got the attenuation reflex we've already talked about, where the tensor tympani and stapedius muscles contract reflexively to dampen that transmission.
A built-in volume control system is pretty genius, honestly.
All right, let's move deeper. Once the stapes vibrate the oval window, what happens next?
So the stapes pushes on the oval window, transmitting the vibrations into the perilymph of the scala vestibuli inside the cochlea. This sets up pressure waves that travel through the cochlea and cause the basilar membrane to move.
Right, and that movement is frequency specific, right?
Yep, we have the tonotopic organization of the cochlea to thank for that. High frequency sounds vibrate the base near the oval window, while low frequency sounds vibrate the apex.
So the cochlea is like a coiled up piano. High notes at the beginning, low notes at the end. And loudness depends on how much the basilar membrane moves and how frequently the hair cells fire, right?
Right again. More movement and faster firing equals louder perception.
Okay, so just a mini recap. Pitch depends on which part of the cochlea vibrates, and loudness depends on how big the movement is and how fast the signals are firing. All right, now how do we turn that mechanical wave into an electrical signal?
That's where the hair cells come in. Sitting on the basilar membrane are inner hair cells with stereocilia on top.
And direction matters, right?
Yeah, that's right. When the stereocilia bend toward the kinocilium, mechanically gated potassium channels open. And because the surrounding endolymph is rich in potassium, potassium rushes in and depolarizes the cell. This triggers calcium influx, neurotransmitter release, and ultimately an action potential in the cochlear nerve.
And if the stereocilia bend away?
Then the potassium channels close, the cell hyperpolarizes, and no signal is sent.
That sounds like a simple but very powerful on and off system.
Precisely like an on-off switch. This system is what converts mechanical waves into electrical signals the brain can process.
And where do those signals go after the cochlear nerve is activated?
Great question. The signals first travel to the cochlear nuclei in the brainstem. From there, they go to the superior olivary complex, which, very importantly, compares input from both ears to help localize where the sound is coming from.
Ah, so that's how your brain figures out which direction a sound is coming from.
Yeah, exactly. After that, it continues via the lateral lemniscus to the inferior colliculus, then to the medial geniculate body in the thalamus. And finally, it hits the primary auditory cortex in the temporal lobe.
And all of that happens within milliseconds. What a crazy efficient system. Okay, so let's go over this pathway again. Sound travels to the ear, then the ossicles, which then goes to the cochlea, then the hair cells, stimulating the cochlear nerve, which then travels to the brainstem, which ascends to the thalamus, and finally, the auditory cortex.
Exactly. Just like that, Adam.
All right, Ahmed. Before we leave hearing behind, let's not forget the two famous bedside tests, Rinne and Weber. They are simple tuning fork tests that help us differentiate between conductive and sensory neural hearing loss, right?
Yep. Let's start with the Rinne test. You first strike a tuning fork and place it on the patient's mastoid bone to test bone conduction. Once they no longer hear it, you quickly move it near their ear canal to test air conduction.
So, bone first, then air.
Yeah, exactly. In a normal ear, or in sensory neural hearing loss, air conduction is better than bone conduction. That's what we call a positive Rinne test.
Okay, so air louder than bone is equal to positive Rinne, whether it's normal or sensory neural.
Yeah, but if bone conduction is louder than air, that's a negative Rinne test, suggesting conductive hearing loss.
So basically, positive Rinne is equal to air louder than bone, meaning normal or sensory neural hearing loss. Negative Rinne is equal to bone louder than air, which means conductive hearing loss.
Perfect.
And how about the Weber test? Isn't that when you place the vibrating tuning fork on the forehead midline and ask which ear the patient hears it in louder?
Yep, that's the one.
And what does it tell us?
If the sound is heard equally, that's normal. But if it lateralizes, like it feels louder in one ear, it depends. In conductive hearing loss, the sound is heard louder in the bad ear. In sensory neural hearing loss, the sound is heard louder in the good ear.
Okay, so conductive pulls it towards the bad ear. Sensory neural pushes it toward the good ear.
Yes, exactly.
All right, so Weber louder in bad ear is equal to conductive. But Weber louder in good ear, sensorineural.
There we go. You've mastered them already.
And what about presbycusis? I feel like every elderly patient has it.
Well, presbycusis is, as you mentioned, age-related, and it's a progressive, bilateral, sensorineural hearing loss. It's the most common cause of hearing loss in older adults.
And what kind of sounds go first?
High-frequency sounds, like S, F, and Th sounds, in speech. So early on, patients complain they can hear people talking, but cannot make out the words clearly, especially in noisy environments.
So it's not just the volume, it's the clarity that's lost.
Yeah, it's gradual, symmetric, and affects both ears.
All right. I feel like this is a good time for a nice question or two to really solidify information for our listeners. I'll go first. Which nerve is mainly responsible for the sensory innervation of the external auditory canal and outer surface of the tympanic membrane?
That would be the auriculotemporal nerve, a branch of the mandibular division of the trigeminal nerve, V3. My turn. During the Rinne test, if bone conduction is greater than air conduction, what type of hearing loss does that suggest?
That would indicate conductive hearing loss. All right, Ahmed. Now that we've nailed how we hear, let's switch gears a bit and talk about how we balance. Because I know the inner ear doesn't just stop at hearing.
The inner ear also contains the vestibular system, which is all about balance, detecting head movements and maintaining posture. It's like our internal gyroscope.
So if the cochlea is the sound department, then the vestibular apparatus is the balance department?
Yep, exactly. It's like our body's own fancy stabilizing camera equipment. It's pretty cool. Now, the vestibular apparatus includes three main structures: the utricle, the saccule, and the semicircular canals.
So basically that's three parts: utricle, saccule, semicircular canals. Got it. And what do each of them do?
Let's break it down. The utricle and saccule are responsible for detecting linear acceleration. That means they sense movements like going up and down in an elevator or moving forward in a car.
So they're like motion detectors for straight line movements?
More specifically, the utricle detects horizontal acceleration, like when you're riding a car forward or sideways, whereas the saccule detects vertical acceleration, like going up and down in an elevator.
Okay, pause. So utricle equals side to side or forward backward motion. Saccule equals up down motion?
Yeah, perfect.
And how do they actually sense that movement?
Inside both the utricle and the saccule, there's a specialized area called a macula. These maculae contain hair cells, similar to the ones in the cochlea, but they have something extra: a layer of heavy crystals called otoliths sitting on top.
Otoliths? Like little rocks?
Yeah, exactly. Otolith literally means ear stone. These crystals give weight to the gelatinous membrane sitting over the hair cells. So when your head moves, gravity or inertia causes the otoliths to shift, bending the hair cells underneath, and that bending sends information to the brain.
That's awesome. So it's like a rock sliding on jelly, pushing on tiny hairs to tell your brain, hey, we're moving.
That's actually a perfect analogy.
All right. So that's linear acceleration. But what about spinning movements?
Spinning or rotational movements are detected by the semicircular canals. There are three canals: anterior, posterior, and lateral, and they're arranged at right angles to each other, kind of like the three axes of a 3D graph.
So basically, no matter which way you turn your head, at least one canal will catch the movement?
Exactly. Each canal detects angular acceleration, meaning head rotation. For example, nodding yes activates one canal, shaking your head no activates another, and tilting your head toward your shoulder activates the third.
Okay, one for yes, one for no, one for tilting. That's a clever setup.
Now, at the base of each semicircular canal, there's an expanded area called the ampulla, and inside each ampulla is a sensory structure called the crista ampullaris.
Wait, crista ampullaris? Sounds fancy.
Yeah, it is. The crista ampullaris is packed with hair cells, just like in the cochlea and the maculae. These hair cells are embedded in a gelatinous structure called the cupula. When you rotate your head, the endolymph inside the canal lags behind because of inertia, pushing on the cupula and bending the hair cells.
So it's like spinning a water bottle. The water lags behind and pushes on the inside walls?
Perfect. That's a great way to picture it.
And when the hair cells bend, They send signals telling the brain which way and how fast the head is turning?
Exactly right. And that information is super important for reflexes that keep your vision stable and your body balanced when you move.
Man, the inner ear is way more than just hearing.
100%. And it's working constantly in the background to keep you upright, balanced, and oriented.
So, how does the vestibular system actually work with the rest of the body to keep us balanced?
Great question. Balance is really a team effort. It's not just the vestibular system working alone. There's constant integration of inputs from three systems: the vestibular system, the visual system, and the somatosensory system.
So, the ears, eyes, and body sensory feedback are constantly talking to the brain?
If even one of them is disrupted, like when you close your eyes, your balance gets shakier.
Right, like when you're trying to stand on one foot with your eyes closed and suddenly it's a lot harder.
Bingo.
Okay, let's focus on the vestibular system for now.
In the vestibular system specifically, the utricle and saccule detect linear acceleration, which are straight line movements, while the semicircular canals detect angular acceleration, which are rotational movements of the head.
So the utricle and saccule are for horizontal and vertical movements, while the semicircular canals are for rotating your head. That makes sense, because the semicircular canals are curved, so they go along the rotation, and they all use bending of hair cells to send their signals?
Yes, movement causes the endolymph to shift, bending the hair cells, which then send signals to the brainstem and higher centers.
Alright, explain the vestibulo-ocular reflex. That one always gets me.
So the vestibulo-ocular reflex is crucial for stabilizing your vision when you move your head. Basically, when you turn your head, your eyes automatically move in the opposite direction to keep your gaze fixed on a target.
Like the eyes counterbalancing the head to keep the world steady.
Yeah, the semicircular canals detect the rotation, send signals through the vestibular nerve to the vestibular nuclei, and then to the cranial nerves controlling the eye muscles to move the eyes accordingly.
So head movement detected by the ears, then sent to the brainstem, then sent to the eye muscles, which adjust instantly.
When you spin around, your eyes move in two phases. First, there's the slow phase where your eyes drift slowly in the direction opposite to the direction of the spin. Then the second phase is the fast phase, where your eyes quickly snap back to the center.
And this is related to nystagmus?
Yeah, nystagmus is essentially an exaggerated or prolonged vestibulo-ocular reflex.
So slow drift, fast flick.
And importantly, the direction of the nystagmus is named after the fast phase.
Okay, so if the fast flick is to the left, it's called the left beating nystagmus.
Absolutely. The fast phase defines it.
And clinically, if someone has nystagmus while just sitting still, that usually points to a vestibular problem?
Exactly. It means there's asymmetric input from the vestibular system.
And that brings us to the caloric test.
The caloric test uses warm or cold water to create fake convection currents inside the semicircular canals, mimicking head rotation.
So temperature tricks the ears into thinking the head is turning?
When warm water enters the ear, it makes the endolymph rise, tricking your brain into thinking your head's turning toward that side. Cold water does the opposite. It makes the fluid sink, so your brain thinks you're turning away.
So, just remember that we go towards a warm hug and not a cold one. Or, alternatively, you can remember it with the cows mnemonic. If you spell out cows, it goes C-O. So that's cold to the opposite direction, and after that, it goes W-S. So that's warm to the same direction.
Never forget the cows, Adam. Cold water causes nystagmus to beat to the opposite side. Warm water causes it to go to the same side.
It's such a clever way to check the brainstem, even in comatose patients.
Exactly right.
Now that we know how the vestibular system senses motion, keeps our eyes stable, let's talk about where all that information goes inside the brain. What are the actual pathways?
Absolutely. So once the hair cells in the utricle, saccule, and semicircular canals detect movement, the signals travel through the vestibular nerve to reach the vestibular nuclei in the brainstem.
And where exactly are the vestibular nuclei?
They're located in the rostral medulla and the caudal pons, basically at the area where the brainstem starts merging into the cerebellum.
Okay, so vestibular signals hit the brainstem first.
Exactly. And from there, the signals get distributed in several different directions depending on what the brain needs to do.
And what are the main destinations?
Okay, so first up, the spinal cord via the vestibulospinal tract. This helps adjust your body posture.
So when you trip over nothing in public but somehow don't fall, thank that pathway.
Yeah, exactly. Next, signals go to the cerebellum to fine-tune balance and coordination. It's like your brain's quality control department. Then it gets even cooler. It sends fibers to the cranial nerve nuclei that control your eye movements through this bundle called the medial longitudinal fasciculus, or MLF.
That's the same system that helps with balance and also keeps our eyes from going haywire?
Yep, that's how your eyes stay focused when you turn your head. Now, last up, the thalamus and the cortex. That's for the conscious perception of motion, and that's basically how you're aware that you're moving, spinning, or falling.
And the cranial nerves it sends for the eye movements are cranial nerves 3, 4, and 6, right?
Yeah, exactly. Those are the cranial nerves that are responsible for eye movements.
Okay, so we said that the vestibular nuclei in the brainstem send fibers to spinal cord for posture, cerebellum for balance, eye muscle cranial nerve nuclei and MLF to stabilize gaze, and finally, cortex for awareness of motion.
Yep, all those different branches work together so we can stay upright, track objects with our eyes, and feel oriented in space.
Ahmed, you mentioned the MLF, which I keep hearing about but never fully understood. What exactly is it?
The MLF, or the medial longitudinal fasciculus, is a very important, heavily myelinated bundle of fibers that acts like a rapid communication highway between the vestibular nuclei and the eye movement centers.
So it's like a hotline connecting the ears and the eyes?
Exactly. When your vestibular system detects head movement, the MLF ensures your eyes instantly adjust by coordinating cranial nerves 3, 4, and 6. It keeps your eyes together during head motion.
Alright, so thanks to the MLF, both of my eyes move smoothly together when I turn my head.
Definitely. Without the MLF working properly, you'd get disorganized eye movements, which means that your eyes wouldn't track objects smoothly during head movement.
What happens if the MLF gets damaged?
So lesions in the MLF can cause something called internuclear ophthalmoplegia. It's where one eye fails to adduct properly when trying to look side to side, but convergence remains intact.
So when that patient tries to look left or right, one eye just lags behind?
Exactly.
So Ahmed, before we wrap up today's episode, let's do a big quick-fire recap. We've covered a ton of ground.
Absolutely. Let's start at the beginning. The ear has 3 main parts: the external, middle, and inner ear.
Right. The external ear collects sound through the auricle and auditory canal, funneling it onto the tympanic membrane at the middle ear.
The middle ear amplifies that sound using the 3 ossicles, the malleus, incus, and stapes, placing pressure onto the oval window.
Plus, we have the middle ear muscles, the tensor tympani and stapedius, protecting the inner ear from loud sounds with the attenuation reflex.
Then we reach the inner ear, where the cochlea takes care of hearing, while the vestibular apparatus handles balance.
In the cochlea, sound waves create fluid movements that bend hair cells in the organ of Corti. That bending opens potassium channels thanks to the endolymph, triggering electrical signals.
Pitch is coded by the exact location in the cochlea where the basilar membrane vibrates. So high frequencies trigger the base of the cochlea, while low frequencies trigger the apex.
And loudness is all about how much the basilar membrane moves and how fast the neurons fire.
We can use simple clinical tests like Rinne and Weber to differentiate types of hearing loss.
If Rinne is positive, aka air conduction is better than bone, then that is either normal or sensory neural hearing loss. But if Rinne is negative, meaning bone is better than air, that suggests conductive hearing loss.
And in Weber, if the sound lateralizes to the bad ear, that points to conductive hearing loss, while lateralizing to the good ear points to sensory neural hearing loss.
Speaking of sensory neural hearing loss, we also covered presbycusis, the classic age-related bilateral inability to hear high-frequency sounds.
Exactly.
Then moving to balance. The vestibular system detects linear acceleration using the utricle and saccule, and it detects rotational acceleration by the semicircular canals.
The utricle handles horizontal movements like driving forward, while the saccule picks up vertical motion like in an elevator.
And the semicircular canals, organized like a 3D graph, catch every possible rotation of the head.
At the base of each canal, the crista ampullaris detects movement by the bending of the hair cells inside the cupula.
And all this sensory input drives the vestibulo-ocular reflex, keeping your gaze steady when your head moves.
And when the vestibular system gets tricked, like spinning in a chair, you get nystagmus with a slow drift and a fast corrective flick of the eyes. The direction of the nystagmus is defined by the fast phase.
We even use the caloric test clinically. Warm water causes nystagmus to the same side, cold water to the opposite. Just remember, the hugs or the mnemonic cows.
And all vestibular signals head to the vestibular nuclei in the brainstem and get sent to the spinal cord, cerebellum, cranial nerve nuclei controlling the eye movement, and also to the thalamus.
And don't forget the medial longitudinal fasciculus, or the MLF, which keeps eye movements perfectly synchronized during head turns.
Exactly. Without it, you'd get disorganized, jerky vision when you move.
From catching sound waves to stabilizing balance, the ear really is one of the body's most powerful multitaskers.
Yup, it's constantly working in the background to keep us hearing, standing, moving, and oriented in the world.
Alright, Ahmed, before we wrap up completely, let's throw in some quick practice questions to lock everything in. You ready?
Let's do it.
Which part of the vestibular apparatus detects vertical linear acceleration?
That would be the saccule.
In the caloric test, if you irrigate the right ear with cold water, which direction will the fast phase of nystagmus be?
To the left. Cold water causes nystagmus to beat to the opposite side. Remember, cows. Cold opposite, warm same.
Last one. What is the most common cause of bilateral, symmetric, high-frequency hearing loss in elderly individuals?
That would be presbycusis.
And that's a wrap for today's deep dive into the ear, anatomy, hearing, balance, pathways, clinical tests, and everything in between.
Seriously, the ear is doing so much more than people think. Detecting sound, maintaining balance, stabilizing vision. It's non-stop work.
Absolutely. Thanks for joining us today, whether you're reviewing for exams, prepping for clinics, or just love good physiology. We hope this episode made things a little clearer.
And if it did, make sure to share PodBites with a friend and follow us as we've got a lot more high-yield episodes coming your way.
That's it for today on PodBites. Until next time.